Okay. Yeah. Hello and welcome to the ATAI seminar for this week. Happy to see all of your attendance, and we have a very exciting speaker today. Before that, I want to acknowledge that the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of the First Nations, Métis, Inuits, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. I also want to remind you of the ATI Research Day. In the chat, you will find a link. Please register. That's happening on March 26th. And then move on to introduce our speaker for today. It's my great pleasure to introduce Dr. Filip Rega, who is the head of the clinic of the Department of Cardiac Surgery of the University Hospital in Leuven, Belgium, and is a full professor at the Department of Cardiovascular Sciences at the Catholic University Leuven. He's chair of the University Hospital Transplant Program, and his clinical and research focuses on programs for valvular heart disease, congenital heart disease, and transplantation. And he is the PI of the NIHP 2019 trial that compared the HOPE approach with standard preservation, and HOPE stands for the role of hypothermic oxygenated perfusion to preserve the heart prior to transplant. And that is the title of his presentation today, Hope for the Heart. Thank you for being here, Dr. Rega.
Thank you, Simon. Thank you, Sean, for the kind introduction. From my side, I can only tell good evening, but I imagine it's midday, so the sun is at its highest point in Alberta. This is my first slide, simply as part of to orient yourself. On your left upper hand side, you see Belgium squeezed between the Netherlands, Germany, and France, and we have to cross the channel to go to the United Kingdom. And there in the center, you see Leuven. We are a 15-minute drive from Brussels, our capital. Leuven is a medieval town. It's a small town, actually. We only have 100,000 inhabitants. And a population of 60,000 students that arrive each year on the 1st of October. And you see some of the medieval, this is not medieval, this is high Gothic. You have in the depth, it's this town hall. On the right-hand side, you see part of the church. And most interesting for you, definitely for the young people, this is the old market. On the right upper hand side, this is where you can spend your evenings in the summertime. It's a really fun place to be. According to the Times High Times Education ranking, we are Europe's most innovative university. But I'm sure that doesn't interest you. What will interest you is the fact that we have a large brewery, one of the largest in the world, the Stella Artois brewery. And that explains perhaps the statue on your right lower hand side. And this figures a student that pours in. It should be science, but with the largest brewery just in the center of town, you can also imagine it is it's beer. And I guess you need both to graduate at a certain point in your life. We celebrate this year the foundation of our university, and we were founded in 1425. So we celebrate the existence of 600 years. I have one declaration of a conflict of interest. I was principal investigator of the non-ischemic heart preservation trial, as Simon already alluded to. And for that, I received a research grant. And I will discuss at this point the use of a non-CE label device, the ex vivo head, when it comes to DCD heart transplantation. This slide depicts the number of hearts we transplant in Leuven. And as you can see, we started to transplant by the end of the 90s. and we do transplant about 23 hearts on an average per year. 2024 was an exceptional year where we reached an all-time high of 34 hearts per year. So an exceptionally good year. And at the end of my talk, it will become clear why this is, because new technology when it comes to heart transplantation explains this jump. These are numbers you're all familiar with. This is a slide that is updated each year by the International Society of Heart and Lung Transplantation. In green depicts the number of transplants in North America, and in yellow it's Europe. This slide tells you something more on what it means to be a larger transplant center. I do not know how many transplants you perform in Alberta, but as you can see, most transplant centers only transplant between 10 and 19 hearts per year. And you start to become a large center if you transplant somewhere between 20 and 29. And as I mentioned, last year, we reached 34. So we start to become one of these rare, larger transplant centers. What is changing over time? And this slide depicts three decades where you recognize a shift in the demographics of our patients. If you look to the area 92-2000, then you see that the ischemic cardiomyopathy was highly prevalent, also the dilated cardiomyopathy. But slowly, when you come to a more recent area, you see that the ischemic cardiomyopathy start to decrease in numbers, dilated becomes more and more. And if you take a closer look in detail, you also see that congenital heart disease start to increase from 1.7% in the first era to 2.6, and in the latest registry report, it's even 3.1. So each 20 years it starts to double. So this is how you have to look to the future. More complex, we will perform much more complex transplantations as we do right now. So the first observation is that, and you all recognize, for those that are into transplantation, that the demography of our patients is changing. Two things I didn't mention is the fact that nowadays, actually more than half of our patients do have an LVAD. We do have more indications for multi-organ transplantations. And as I mentioned, I also mentioned congenital heart disease. So transplantation is becoming more and more complex, reflecting the need to extend our ischemic intervals to be able to do those transplants. We also have to recognize, and I will detail that later a bit more, that the demography of our donors has changed. And there continues to be a need for more and more donor hearts. And strangely, if you look to the beginning of transplantation, by the end of the 60s, static cold storage for a very long time continued to be the gold standard preservation technique. Actually, it still is. There is some delay when I forward my slide, so this is why I sometimes talk a bit in staccato. When it comes to new preservation technology, we have to make the difference between static preservation, meaning you put the heart into a box, but instead of putting it on ice, where we know the temperature after 2 hours will go below 4 degrees centigrade, and where you will have the problem of frost damage, more conditioned ways to preserve the heart start to come up onto the market, with the most famous one, the paragonic system, that in the US is becoming actually the standard. On the right side here, you recognize a sort of homemade paragonics device. When it comes to dynamic preservation, machine perfusion, we have to recognize the importance of the transmedics device, where a heart is preserved in a normothermic way at 37 degrees. But there is a new kit on the block, the Xvivo Heart Box, coming from Lund in Sweden. It's invented actually by Stig Steen. a Norwegian cardiac surgeon that spent all of his life in Lund in the south of Sweden. And the main target of that device is hypothermia. It's 8 degrees centigrade, the low pressure 20 millimeters of mercury. Also that I will detail later on. Just to highlight some of the important facts that have been reached with both of the technologies. When it comes to static, I refer here on the left-hand side to a recent publications by the Vanderbilt people, where they took out the heart in Anchorage and implanted that in Nashville, which led to a 10-hour preservation interval, and the patient did apparently really well. When it comes to dynamic preservation, I here go back to 3 papers starting in 2015, with also explaining the story where the Transmedics device was used and highlighting what is possible with that. You see here a 10-hour preservation time, even a 16-hour preservation time ex vivo in 2019. And it also includes a reference to a series of patients with complex cardiac heart disease problems. On your left-hand side, you see some of the Paragonix data based on, these are US data, registry data. So they, up to this point, they don't have any results from randomized trials, so they only report registry data, but they are quite impressive. These are 2 propensity matched cohorts, 150 patients in each arm. And if you look to 1-year survival, quite impressive, almost a 10% difference in favor of the Paragonix Sherpa-Pak preservation device, and that was statistically significant in this comparison. On your right-hand side, there's a recent publication, and now I'm again referring to dynamic preservation with the ex vivo heart box, so the cold preservation, where a heart was preserved in Martinique, a Caribbean island owned by the French, and it was put on the regular carrier, an Air France flight, and then transplanted where the clamp was open 12 hours later in Paris. When it comes to cold preservation, ex vivo heart box, I also have to refer to a publication by our Australian colleagues. David McGiffin was the first author. As you can imagine, as by the way also in Canada, distances between centers, definitely between East and West, are extremely long, and up to the use of the ex vivo heart box, it was for them not possible to transport hearts from one side to Australia to the other, but with the ex vivo heart box it became possible. And in this manuscript they describe the successful outcome. I think it was in 36 cases where only 1 patient needed ECMO, so 1 PGD, and all of them did later on really well. So survival at 30 days for all of these 36 cases was 100%. I will focus more deeply into the ex vivo heart box system. And perhaps this is too small for you, but here I refer to literature going back to the 90s even, and for those that are interested, please dive into that. It's if you do the search on Stig-Steen, you will find many references where he starts to elude all of the crucial elements that made successful heart transplantation with ex vivo heart box possible. And one of the more famous publications is the one on your left lower hand side, where he describes the safe orthotopic transplantation in hearts that were preserved for 24 hours and successfully transplanted in pigs. All of these pigs survived, and this led to the first in-man trial, where you see the reference of on your right upper hand side. So a non-randomized open label phase 2 trial. So it's a safety and feasibility trial in humans. The end results are not published yet because one of the issues they had is that they changed from one device to the other. but probably the results will come out in the next 2 years. What is the basic principle of the ex vivo heart box? Where can I start? So you see here on your left upper hand side how a cannula is mounted into the aorta and fixed. It's a very ingenious design because it's a sort of automatic de-airing system to avoid bubbles going into the coronary arteries. You also recognize here a tube going through the left atrium, through the mitral valve, and this is to prevent distension during preservation. And then the heart is mounted into the system that you recognize. It's a box, it's a cooler box that keeps the temperature really stable at 8 degrees. So you avoid frost damages. The flow is basically somewhere between 100 ml per minute to 200 ml per minute, depending on the coronary resistance. The solution on itself is a solution existing of 2 components. It's the ex vivo heart solution with the composition explained on the right side. And you recognize a classical electrolyte composition, glucose as substrate, but very importantly, albumin to 75 grams per liter. So actually the total protein content, physiological protein content is changed through albumin to have really a physiological oncotic pressure, and thereby you prevent edema formation. There are some hormones like thyroid hormone, cortisol, insulin, noradrenaline and adrenaline in a low dose, and perhaps surprisingly, and this is not for the surgeons, but it is necessary, also cocaine is added. And to explain a bit the background of the cocaine, Stiksteen's experiment started to succeed when he added cocaine, because he had to recognize that following brain death, all of the synapses of the nervous system of the heart were saturated with catecholamines. And cocaine is a noradrenaline reuptake blocker. So you make the synapses susceptible again for catecholamine. So as soon as you start your low dose of catecholamines after your transplantation, these hearts become responsive again for catecholamines. And so you're able to maintain a really stable pressure. And with that, I hope I've highlighted all of the specific aspects. Perhaps one thing to add, yes, red blood cells are added. And basically what we did is we looked at the rhesus factor of the recipient, and depending on a positive or a negative rhesus factor, we added red blood cells up to a hematocrit of 15%. So we added either O negative or O positive blood cells to packages. After the first in-man trial data, the initial small number data came out, we started to gather to initiate the non-ischemic heart preservation trial, which ran in Europe in 15 centers in 8 countries, where we compared the golden standard, static cold storage, ice preservation with hypothermic oxygenated perfusion. I'm going to explain a bit where the NIHP terminology comes from, because at a certain point, Stiksteen was convinced that in the way he looked at preservation, and he was able to even in laboratory experiments to go for 48 hours, he considered this to be a non-ischemic way to preserve the heart. And this became then the acronym of the trial. By design, it was an RCT, a randomized control trial. And as you know, only very few randomized control trials have been performed in this area in medicine. By design, the superiority, so even braver. And in total, we needed to include 202 patients in 2 arms, 101 in each. And we looked both at standard as extended criteria. And I will detail some of the donor and the recipient characteristics, but actually there's a difference between North American donors and a typical European donor, because our donors on average are around 50 years and have, as you can imagine, at that age, a lot of more comorbidities. So when we recruited in 15 centers all across Europe between 2021 and 23. Our primary endpoint was a composite primary endpoint, where we looked to a time to first event that had to be reached within 30 days. And the different components of the endpoints were, first of all, cardiac-related death, moderate or severe primary graft dysfunction of the left ventricle, according to ISHLT criteria. And yes, you can debate on ISHLT criteria. Primary graft dysfunction of the right ventricle, acute cellular rejection graded 2 or more, again, according to ISHLT criteria, and finally, graft failure. That is failure requiring a mechanical circulatory support or retransplantation after 24 hours. If it's before or within the first 24 hours, you're talking about primary graft dysfunction. I'm sorry, again, there's some delay in transitioning from one slide to the other. When we look to the inclusion and exclusion criteria of recipients and donors, I think these are very obvious in and exclusion criteria. So we tried to be inclusive as possible. So for the recipients, it's age above 18 years and listed for transplantation. And if you look to the list of exclusion criteria, I think you can recognize these are the classical exclusion criteria: previous transplantation, grown-up congenital heart disease, kidney failure, and a number of other people. Mechanical circulatory support was accepted. So, but not ECMO patients. This is, I needed to specify that to be clear here. When it comes to donors, age above 18 years and below 70, and as exclusion criteria, a previous sternotomy and DCD. So we only looked at DBD donation. This is the patient flow chart. So we screened more than 1,000 files, had close to 600 signed informed consents, and actually we randomized close to 230 patients into 2 arms, which we call the intention to treat, 119 in the hypothermic preservation group, and 110 in the classical statical standard cold storage. But as you all have to recognize, being randomized does not necessarily mean being transplanted. A lot of things happen at 2 o'clock in the morning. So you end up with a modified intention to treat population, with in the HOPE arm 101 patients, and in the static cold storage 103 patients. There were still 6 device deficiencies leading to transplantation with static cold storage. And then you have the per protocol population, and in the end also the safety population. The results that I will discuss are based upon analysis from the modified intention to treat. All of the results were checked in the per protocol and the safety population, and they were confirmed. But I only will discuss the modified intention to treat. 3 HOPE hearts, so where the heart was put on the device, were not transplanted. In 2 cases, it was because of a malignancy that was only defined or identified once the heart was out and put on the machine. And in one case, the recipient died because of an aortic injury. Of important notice is to mention that no hearts were discarded due to device malfunction. And we feel that this technology is in that sense something that you can rely on, which is not always the case when you use normothermic ways or normothermic dynamic preservation techniques. These are the donor characteristics, and of interest, this is a typical European donor population. The randomization did work. On average, these donors were close to 50. They do have some comorbidities, but very well balanced between the two arms of the trial. When it comes to recipients, a standard European recipient population, average age 56, 58, smoking history, diabetes. 1 in 3 was on a ventricular assist device. But also again here, the randomization did do its work, and you recognize two balanced recipient populations. Some details on the preservation. In the HOPE group, the total preservation time was 240 minutes. In the static cold storage, it was 215, and this difference is explained by the fact that, of course, you need to take out the heart and put it on the device, which on average takes you about 25 minutes. All of the other preservation time intervals were really balanced between the two populations. Oops, this is actually the most important slide, so I cannot forget this. So this is the Kaplan-Meier curve of the primary endpoint. As I mentioned, it's the composite primary endpoint. You see different curves. The blue is HOPE, and in red, it's the static cold storage. 19 events noted in the HOPE population and 31 in the static cold storage population. But, and this is why it's highlighted, a lot of things happened in the first 24 hours. In the next slide, I will explain this is related to primary graft dysfunction. If we calculated the p-value of these Kaplan-Meier curves, we ended up with a p-value of 0.059, so actually not statistically significant. But you can calculate whether the different components of the primary endpoint are evenly distributed, yes or no. And actually we reached a p-value of 0.016, so they were non-evenly distributed, and this allows you to separate the different components and to look more in detail to them. And this is why we come up with the fact that primary graft dysfunction was noted 29 times in static cold storage and 11 times in HOPE. I have to underline that these primary endpoint events were blindly adjudicated by someone independent from the randomization, so unaware in which arm of the trial the patient found him or herself. So 29 events in static cold storage and 11 in HOPE, which was statistically significant different with a p-value of 0.0025. And if you calculate the risk reduction, you come to a risk reduction of 61% in favor of HOPE versus static cold storage. So 61% risk reduction in primary graft dysfunction. And this is looking at patients, not at events, but similar findings. But it highlights the difference between severe PGD, 20% versus 5%. Adverse events, and then let's go to the bottom line. Major adverse cardiac transplant events, 19% versus 33%, which was also statistically significantly different. This led to the following conclusion. So this is one of these rare randomized controlled trials that ran in 15 European centers, and we compared static cold storage with hypothermic oxygenated perfusion. And we found a 61% risk reduction of PGD in favor of the hypothermic preservation group. And we found it important also to note that no hearts were lost due to device malfunction once the heart was on the device. So I'm going to slowly go to applications of the device. So we already found a good indication in our classical DBD donors, but with standard preservation intervals in a standard transplantation setting. But as I mentioned in the beginning of my talk, we have to recognize that the demography of our donors is changing. We're doing much more complex patients as we did 10, 15 years ago. The need is still there. And we also have to recognize that the demography of our donors itself is changing. I will detail that in the coming slides. So we have the classical donors after brain death, and two very important declarations made transplantation possible. It's the consensus statement from the Harvard Commission on Brain Death that goes back to 68. This is the time when transplantation took off. And then later on in 81, the neurological criteria in the Uniform Determination of Death Act were specified. But since many years by now, actually, we also start to use the organs from donors after circulatory death, where donors are deceased after irreversible arrest of the circulation. And just to give you one number, but in 22 in the US, this was relevant in 22% of all the donors in the US. And this is definitely true for liver, kidneys, also lungs, and since a few years now, also for hearts. This is how this translates into data from our own center, where you see the transition from DBD donors to DCD donors. And actually in 23, more than half of the organs, definitely for abdominal, came from DCD donors. But what does it mean for hearts? Well, our first DCD heart was transplanted in 2018 using thoraco-abdominal normothermic regional perfusion, so in situ reperfusion of the heart. You see that we didn't perform any DCD hearts in 23 because we had to halt our program. And since 24, we are transplanting again hearts from DCD donors, but now we shifted to direct procurement. And these are just two references of publications. The first one goes back to 2020, where we describe the thoraco-abdominal NRP perfusion with distant procurement and static cold storage after the NRP. And then also our first three cases where we took the heart from a DCD donor and in a setting of direct procurement, published in 24 in the Journal for Heart and Lung. These are all the countries, and Canada is included, but you have to explain me more on what DCD means for heart transplantation in Canada. But you see the different countries, Australia, the UK, Belgium and the Netherlands, as well as the states where hearts are transplanted from DCD donors. This slide depicts actually the different possible combinations where you start with either DBD donors and DCD donors on the other hand, and the different types of technology that you can use. I have to recognize here Transmedics because definitely the people from Sydney, Australia, that already in 2015 documented in a Lancet manuscript, described a successful transplantation of 3 hearts transplanted coming from a DCD or donor. And actually in 2022, TransMedics received an FDA approval to use the device in the setting of DCD organ donation. This is our Leuven protocol when it comes to thoraco-abdominal NRP. We have to follow Belgian legislation, and we are in Belgium allowed to do some maneuvers before the withdrawal of life-sustaining therapy. So we're, for example, we can give heparin, and we can do some manipulations. In Leuven, we discussed a lot with our ethical commission. In our setting, we're able to put the guide wires into the groin, as you see here on the left lower picture, where a patient is prepared prior to withdrawal of life-sustaining therapy. We have to include, according to Belgian law, a 5-minute no touch before we can declare formally death. But I think it was 2019, there is this famous Manara paper where they started to argument that we didn't fulfill the definition of irreversible cessation of circulation to the brain. And this is mainly due because of the first 2 intercostals that have cross circulation with the posterior brain circulation. So where you can imagine that there might be some kind of recirculation possible. In order to overcome that, they propose 2 possible strategies. The first being to leave the supraaortic vessels open and to make them drain passively, or another technique, and this is the one that we applied, is to drain actively on the 3 supraaortic vessels. And you see here a patient that is prepared, and actually during the procedure itself, with these catheters in the neck, you see how the 3 supraaortic vessels are cannulated separately and drained, and with that we transplanted successfully another 6 patients. In total, I think we've done 11 thoraco-abdominal NRPs, and actually all of these patients do really fine. And this is our basic protocol in 3 steps. And this is a bit where we ended up with, because after that Manara paper, we had a really intense debate internally with the donor working group that continued to argue that, look, we have to be extremely careful. And in the it ended into a halt into our program. And this explains, if you go to the beginning of my presentation, why we didn't use any DCD hearts in 23. But by the end of 24, by the end of 23, we started to have the results from the NIHP trial, which was really beneficial, and we were able to convince our government to use a non-CE approved device in the setting of DCD transplantation. And it took us 2 months to build the program, actually, to write down the protocol and to go through the different exercises. And by March 24, we were actually ready, and we transplanted actually very soon after, early March, our first patient in the setting of direct procurement. So after the 5-minute handoff, you open up the sternum, you do a sternal laparotomy, and actually together with the lung guys and the abdominal guys, you take out the organs, and we put it on the, you flush them in situ, and you put them then on the Xivo hard box. And these are the results in our first 9 patients. I first depict the donors, and as you can see, on average, our donors varied from, I have to be careful here, the youngest being 12, the oldest being is 75, patient donor number 7. And an important number to remember is the functional warm ischemic time. It's the time between when the pressure drops below 50 millimeters of mercury and when you flush the heart. And that varies in a Belgian setting from 14 minutes up to the longest being 21. And we expect, or we accept hearts wherever that timing is below 30 minutes. You also see the perfusion times on the Hope device, and actually the longest being 319 minutes. So this is more than 5 hours of perfusion time. In total, out of body time in that patient was more than 413 minutes. So actually really long intervals, and I can assure you patient 7 is still alive and kicking and at home. Patient number 8 is a specific patient, but that does not relate to the donor, but to the recipient. So these are the results in these 9 patients. The recipients varied from 13 years being the youngest to 65 being the oldest, many of them on a VAT. Oh, and I'm go back one slide because I think it's also important to mention that most of these donors were Maastricht category 3. So these are the patients, the neurological patients, but 2 euthanasia patients, patient number 6 and patient number 9. So back to the results, many on a VAT. And as you can see here, patient number 8 that deserves some attention, that was on a veno-arterial ECMO. Actually, we consider this to be a salvage patient. It was a patient that was referred to us from another hospital. He came out of aortic root surgery with a stone heart. It was a young patient that before his surgery was actually a clean medical record patient. He only had a dilated root and some kind of aortic stenosis, but even without any complaints. He was on a VA ECMO. We transplanted him. We tried to put him on a high urgency list, but we didn't receive a permission within Eurotransplant. And within 24 hours, we received a DCD offer. And so we gave that offer to him. He continued to be on VA ECMO for, I think, 5 to 6 days, and then we converted VA to VV ECMO, but somewhere between in the 3rd, going to the 4th week postoperatively, we lost him to intractable lung disease. He also attracted COVID, so unfortunately, we lost patient number 8. But all of the other patients did really fine. And even in these first 4 patients, you recognize that we were able to extubate these patients on the table even. Yes, we had a few surgical complications. One needed a drainage in the 2nd week. One needed a refixation on day 4. And this is patient number 9. We also needed a revision. I think this was within the first 24 hours. ICU stays really acceptable to low. Total hospital stays also actually acceptable to low. Patient number 7 needed more time. And you see the cardiac indexes at day 30, which are actually more than acceptable to too high. And all except patient 8 are alive at 30 days. Actually, by now, we transplanted 17 DCD hearts. And 16 except patient number 8 are still alive. And with this, I come to the conclusion of my presentation. And so I started to go over some of the changes in the demographics we have to recognize in our recipient population. Yes, we still need donor hearts to be able to transplant these very sick patients, but there is, if you close your eyes and if you have to foresee the future, I guess within 10 years from now, we will not preserve any hearts anymore on ice. Both conditioned static preservation will become standard together with machine preservation. And in machine preservation, I'm convinced that a hypothermic at this point is the way forward. And in the last part of my presentation, I explained the possibility of hypothermic preservation in direct procurement in the setting of DCD organ donation. And with this, I conclude my presentation. The word is back to you, Simon.
Thank you very much, Filip. That was a fantastic presentation and very exciting data. Thanks for sharing it with us. If you have questions, you can either use the chat box or you can just raise your hand and then unmute yourself to ask questions. I noticed that Dr. Fried has also joined, who's kind of leading DCD as well as ex vivo perfusion efforts for hearts here in Canada. As we're waiting, I can maybe start off with a question on the pediatric side, because you've rightfully noticed that our demographics is similar to Australia, and we have very far distances often to go for our hearts. And we've accepted hearts up to 11 hours cold ischemic time, which have done well now 17 years post the transplantation. And we find that the younger the kids are, the more tolerant the hearts are. Did you find the age curve within your patients on the adult side as well, that older hearts were less tolerable to the one or the other technique?
No. And that's a short answer, huh?
Yeah.
But as I mentioned, and do you mean in the you don't differentiate in the setting of DBD or DCD? It's an overall, but in Europe we tend to use hearts of very old donors. Actually, I think in the US the average donor is about 35. In Europe it's more 50. Last week we had an offer from a 64-year-old donor, but we try to look in the trial data to see whether these older donors did better or worse, but we were not able to identify any differences. So, but definitely also not in the negative direction. Okay, so.
Excellent. While we don't have any kind of pediatric size machines available at present, I was curious about your cold ischemic device, because you mentioned that you have kind of your in-house Sherpa pack. Is that something that is commercially available and reusable and does not cost $20,000 for a single-use device?
I'm going to answer it in two ways. So it's about 800 euros. I'm not able to answer whether how many Canadian dollars this is, but definitely a lot cheaper. The problem is regulatory. So it's very difficult to understand that you were able to buy our classical cool ice box in a store, but it apparently it's much more difficult to introduce a box with some technology in it. But in the end we're going to use it, and so but yeah, we're able to maintain the temperature around 80 degrees. At this point we have not used it in a clinical setting, but I know others did. The second part of my answer is when it comes to the hypothermic perfusion, I know the cannula will fit patients up to the age of, if you take off the tip of the cannula, you can use it probably up to the age of somewhere between 1 and 2. Okay, if you go the age of 1, you need a smaller size cannula. What you in fact do with these patients aged 1, 2 is that you take the truncus brachiocephalicus and start to use, if you open that up, you can easily place the cannula at that level without any problems, the classical adult size cannula, except of the bulb.
And from a flow perspective and so on, that should work well?
Yeah.
Okay.
Because it's pressure controlled, so
yeah.
you will have lower flows, but it's a pressure control system, so it regulates itself.
Fantastic. Excellent. We have a question in the chat, but everybody else, if you have questions, please raise your hands or just unmute yourselves and start asking. So this is a question from Diana Toshak asking if there was a sex distribution difference in your patient participants, and were you able to stratify your analysis on the basis of sex to determine if there were differences in outcomes, either sex of the donor organ and or sex of the recipient?
Well, let's go back to both the demographic slides of the donors and the recipients, but the answer is in short, no. So there was no influence. So you see here, as I mentioned, a balanced donor population when it comes to female-male distribution. And from the recipients, yeah, only strangely, 23, 21% female versus 77, 79, but no, didn't have impact on outcome.
Okay, Darren.
Professor Rega, it's very good to see you. I really wish we could have had you come in person, but I'm sure you are happy that you didn't come in person because it is very cold here.
Yeah.
I'm sorry.
It preserves well, I imagine.
Yes, maybe that's why our long ischemic times are so successful. So I'm sorry I missed the first little bit of your talk because I was still in the OR, but are you, for DCD hearts, are you going, do they all get NRP and then the ex vivo system, or do you do NRP, cold storage, and implant?
Yeah, I'll try to explain this by going over this slide. This explains the difference between NRP and machine perfusion. In 2018, our NRP program started, and what we did was we reperfused in situ and then preserved the heart on ice.
Cold storage, yeah.
And cold storage. And actually, I think we were one of the first to describe that protocol.
Yeah.
Because I think in the US, it was all machine perfusion afterwards. And then, as I mentioned, we had to halt our program because of the ethical ongoing discussion, and we shifted to direct procurement with the ex vivo heart box.
Yeah. So, I mean, I think the Papworth guys did have a couple of hearts that they had NRP, cold storage, and then transplant when they were NR or DCD donors in Papworth Hospital. So they didn't have a very
In
long
itself, yeah,
transport difference.
that's
Yeah.
true. You're
I think
absolutely
it was,
right.
yeah, I think it was buried in their series somewhere.
Yeah.
So how, I mean, how did you, can you just, you know, from a surgeon's perspective, you know, we get a little worried if the heart doesn't work after you take the clamp off. You know, how did you feel about using, you know, not having seen the heart beat after, you know, the DCD process until you took the clamp off in the recipient?
Yeah. For some reason, we were never nervous. And there are a few elements I'd like to highlight here. First of all, you do a full assessment prior to withdrawal of life-sustaining therapy. So you come into the OR and you have all of the data of the past hours and days in front of you. You have an echocardiography where you see the heart functioning, and you have hemodynamics in your patients. So you know at that point, this heart is functioning fine. Okay. And then, and I must admit, and this is then the second part of my answer, is that in Belgium, I think we have a good legislation and a good practice in the way that these patients are, they are anesthetized really well. We are able to give heparin. And so the process of dying is pretty swiftly. As I mentioned, that I refer to the functional warm ischemic times, they are actually all short.
They're short.
Okay?
Yeah.
They are between 15 to max 20, 21 minutes. And we know as cardiac surgeons that if you use intermittent cross-clamping techniques to do your coronary surgery, that whatever you do within 15 minutes of intermittent cross-clamp, your heart is going to take well. So if you respect a functional warm ischemic time to be low, then I think there's good reason not to become nervous. Okay,
Yeah.
it's different. I can imagine, and we have because we're doing now a trial with the Netherlands, and there the setting is different. The withdrawal of life-sustaining therapy is performed in the intensive care unit. They do not give comfort therapy to their patients, and then that process of dying is more extended, with a variety of responses depending on the neurological damage. And there you need to be more careful. But also there, if you respect the functional warm ischemic time, and at this point we assume whatever happens below 30 minutes will not harm cardiac function.
Yeah, I think that's a key point, is the functional warm ischemic time. And we we have our own unique situation here, I would say, at the University of Alberta, that we're going to have to work through as we move forward with into DCD heart transplant, whether it's in the pediatric or the adult context. But I have to say, anecdotally, we've had in my lab, we've had permission to take DCD hearts to the lab for the last several years, and they all perform extremely well when I put them onto my ex vivo heart perfusion device, better than the DVD hearts that are declined for transplant. So I have every confidence, just like you have, that once we get into this, we'll have the same experience that other centers around the world have experienced.
So in that sense, we both agree that probably DCD hearts are going to be better than DBD hearts.
Yeah.
Because they didn't go through that catecholamine storm.
Yeah.
And they are much more responsive and less deprived or depleted in whatever kind of function compared to a DBD heart.
I think that is true, Philip. Sorry, I don't want to monopolize this, Simon. I know there's other people who have questions too, but just one comment about that, Philip. I think it has to do with how much they're medicated during the process of DCD, during withdrawal of life-sustaining therapy. Because I've anecdotally definitely seen a very Cushingoid type response during the hypoxic cardiac arrest, where they get very tachycardic and hypertensive. Not dissimilar to what you would expect to see with the process of brainstem death. So I think it depends probably on how what types of medications are given for comfort care, as you mentioned. I think that's a big piece of the puzzle as well. Anyway, you and I can chat about this forever, most likely.
And a short reply to that, in that sense, we were afraid in the euthanasia patients.
Yeah.
Because if you give barbiturates, or if some give potassium, then you might induce some potassium-related or barbiturate-related injury to the heart.
Have you seen that? Has that played out? That concern played out in reality?
First of all, we are extremely careful in the conversation with the people responsible for the withdrawal of life-sustaining therapy in order to not intervene with their practice. So we respect that. But we try to ask the question whether they give, it's a general question, like, do you give cardiotoxic medication? If so, please tell us, because in that way we still can say, no, we're not going to take the heart. I was most scared in the potassium situation, where I was aware that they were going to give potassium, but then we started to calculate, and probably the potassium, even if you give to 80 mg, it's diluted so much, so you have an instant arrest, but it's diluted so much, so there's by no means any way that it's toxic for the coronary. So, and in the end, we never observed any problem.
Well, thank you very much.
Okay, thank you very much. That was a very exciting discussion. And we can leave the line open for you guys. You can still chat for the next hour or two. Otherwise, I want to thank everybody for attending today, and Filip for the excellent presentation. Next week, we have a presentation about accelerating biomarker.